Alterations in cardiac output and tissue perfusion. Disorders of the coronary and peripheral blood vessels. Cardiovascular disease is the leading cause of death in the United States. Common causes are arteriosclerosis, atherosclerosis, clot formation, and vascular spasm. Arteriosclerosis is a loss of elasticity or hardening of the arteries that accompanies the aging process. It's caused by calcium being deposited into the cytoplasm, and this calcium causes the arteries to lose their elasticity. When the left ventricle contracts, the rigid arterial vessels then fail to stretch. The result is a reduced volume of oxygenated blood delivered to organs such as the myocardium, brain, kidneys, and extremities. Atherosclerosis is a condition in which the lumen of the arteries fill with fatty deposits such as plaque. Plaque is chiefly composed of cholesterol, which is a fatty lipid substance. Atherosclerosis is more modifiable than arteriosclerosis. Contributing factors to atherosclerosis include mechanisms of fat formation and metabolism, obesity, and an inflammatory response. Risk factors for atherosclerosis include hyperlipidemia, which is high levels of blood fat, and factors such as gender, heredity, diet, disease such as a metabolic syndrome, and inactivity also contribute. Infections such as Chlamydia pneumoniae, which is a bacterium that commonly causes respiratory infections, has been found in atheromas, that fatty mass in the arterial wall. Inflammation. A relationship between body fat and thrombotic proteins exists that can increase the risk. And multiple factors are additional risk factors for coronary artery disease, CAD, and that includes cigarette smoking, a stressful lifestyle, obesity, diabetes mellitus, and hypertension. So some of the drugs that may be recommended for high fat levels, the high cholesterol, are going to be your anti-lipidemics. This is going to be contraindicated in pregnancy, liver disease, or elevated liver enzymes. Adverse effects of your hyperlipidemics include abdominal pain, rash, headache, myopathy, which is muscle pain, rhabdomyolysis, which is a breakdown of muscle proteins, constipation, and diarrhea. Clients should be encouraged to take your anti-lipidemics of an evening because that's when most of your cholesterol synthesis takes place. So it improves the medication's action. These medications are going to include your statins, such as your atorvastatin and simvastatin. So coronary artery disease. We have coronary occlusion, which is the closing of a coronary artery. This reduces or totally interrupts the blood supply to the distal muscle area. Coronary artery disease precedes coronary occlusion. Left untreated, it will lead to myocardial infarction, or an MI, also known as a heart attack. Symptoms usually do not occur until at least 60% of the arterial lumen is occluded. With coronary artery disease, we see arteriosclerotic and atherosclerotic changes in those coronary arteries that supply the myocardium. Causes include inherited factors, may be the male gender, diabetes mellitus, increased lipid levels, a genetic predisposition, and hypertension. Behavior risk factors include smoking, a sedentary lifestyle, obesity, an aggressive personality, and a high-fat diet. These clients may be asymptomatic or they may just experience fatigue. They may have chest pain, which is also known as angina or angina. It radiates from the chest to the shoulders, the arms, especially the left side, or to the jaw, neck, or teeth. The pain can be described as indigestion, discomfort, burning, squeezing, pressure, crushing, tightness. Atypical symptoms include nausea, fatigue, and dizziness. People that will experience atypical symptoms are going to be those that are female or may have diabetes. We treat this with weight loss, stress management, management of blood glucose, drug therapy such as your nitrates, your beta-adrenergic blockers, your calcium channel blockers, your angiotensin converting enzyme inhibitors, and your diuretics. We can also give supplements of folate or folic acid, vitamin B6 and B12 may also have some benefit. And one of the most recent recommendations is vitamin D. These clients may require surgical procedures such as the percutaneous transluminal coronary angioplasty, which is the PTCA or the cardiac catheterization, a balloon angioplasty, a coronary stent, an arthrectomy, which is removal of the fatty plaque, a coronary artery bypass graft surgery, which bypasses an occlusion, or a transmyocardial revascularization, which is done for clients that have chest pain that don't respond to medication and are not candidates for CABG, the coronary artery bypass surgery. Nurses should assess the characteristics of the chest pain and administer prescribed medications that dilate the coronary arteries or reduce the work of the heart, in addition to encouraging rest. Administer oxygen to improve the oxygen supply to the heart muscle. Excuse me, and educate the client to reduce modifiable risk factors, for example, smoking cessation, and prepare the client for diagnostic tests and treatment procedures. So we have a 55-year-old client that's been diagnosed with CAD. The nurse is teaching the client nutritional aspects of a low cholesterol diet. Which statement made by the client indicates understanding of the diet. Egg whites do not contain cholesterol. A myocardial infarction, or MI, is our heart attack. This occurs when there's a prolonged total occlusion of coronary arterial blood flow, causing tissue death or necrosis. We can have different types of MIs. The transmural infarction is an infarct that extends through the full thickness of the myocardial wall, or a subendocardial infarction, which is a non-Q-wave MI, is a partial thickness. If you look at your slide, you see the ST elevation and ST depression. So we have ST segment elevation would be a STEMI or ST elevation myocardial infarction, or an ST depression would be your non-STEMI, so a non-ST elevation myocardial infarction. If we see those, we know that the client is having an infarct somewhere in the heart. Causes of MI include a thrombosis secondary to arteriosclerotic and atherosclerotic changes or arterial spasms. Arrhythmias and heart failure are common consequences following an MI. Complications include dysrhythmias. More than 50% of deaths from an MI occur within 72 hours for this reason. Cardiogenic shock has a high mortality rate and occurs when 40% of the left ventricle has lost its ability to pump effectively. A ventricular rupture, which is a rupture of the ventricle. The client experiences dyspnea, rapid right-sided heart failure, shock, and a poor prognosis. Ventricular aneurysm, an arterial embolism, where clots form easily in the cavity of the ventricular aneurysm. A venous thrombosis, where we have veins of the lower extremities and pelvis affected. That pulmonary embolism, usually from those DVTs in the lower extremities of the pelvis or, again, the legs. The onset is usually sudden, chest pain, dyspnea, cyanosis, and blood-tinged sputum. Pericarditis, or inflammation of the pericardium, and mitral insufficiency, where we see mitral regurgitation. So with an MI, these clients, men, typically will experience sudden severe chest pain. Usually that pain is going to be substernal, in other words, below the sternum, and it can radiate to the shoulder, arm, teeth, jaw, or throat. Women are going to have more vague symptoms, unexplained fatigue, abdominal pain, shortness of breath, and again, your diabetics are also included in that abnormal or atypical symptoms. Unlike anginal pain, rest and sublingual nitrates will not relieve MI pain, and that pain can last for hours or days. Additional symptoms will include nausea, vomiting, a pale or ashen color, diaphoresis, feeling faint, lightheadedness, or dizziness. So we do lab tests. We're looking at serum enzymes such as a CKMB. We also look at the troponin, which is only present in the cardiac tissue. So it's the gold standard for determining early MI heart damage. We treat it by reducing tissue hypoxia. We want to relieve pain. As long as they're having pain, and that pain is caused by hypoxia, it's caused by ischemia to the tissue. So as long as they're having pain, they're having some damage going on, or they're having some ischemia going on. So we need to relieve it. We need to treat the shock if it's present. We want to alleviate any dysrhythmias and decrease the workload of the heart. So one of the main medications in an MI is going to be nitroglycerin, or when they have angina. It is indicated for stable, unstable, and vasospastic angina. Contraindicated in severe anemia, closed-angle glaucoma, hypotension, because nitroglycerin is a vasodilator, so that would only increase hypotension. It's also contraindicated with severe head injury and in conjunction with erectile dysfunction medications. It does have an adverse effect of a headache, once again, because of that vasodilation, tachycardia, postural hypotension, and contact dermatitis with the topical medications, such as the patches. The patches should never be cut. We never ever cut a patch. And we should not touch that area. But be aware that people that do wear the patches often have the contact dermatitis. It does interact with other nitrate-containing medications, alcohol, beta blockers, benzothiazines, and again, those erectile dysfunction medications. So if the client is wearing a patch, we put the patch on in the morning and remove it of an evening because they can develop a tolerance to the nitrate. If we're giving it sublingual, we can do this with a spray or we can do it with a tablet. If it's a tablet, we dissolve it. We instruct the client not to swallow it or chew it. We can administer it sublingually every 5 minutes times 3 if they're not pain-free. Make sure that you monitor the blood pressure. Again, we're causing vasodilation, so we are going to drop the blood pressure. The pills should be kept in a dark bottle, the original container, because exposure to air and moisture will actually cause deactivation of the drug. And because it causes that vasodilation and headache, it may also require administration of acetaminophen for the headache. Thrombolytic therapy may also be done to help treat an MI, but this needs to be done within 2 hours of symptom onset to help reduce the area of injury. And the percutaneous transluminal coronary angioplasty, the PTCA, or the cardiac catheterization, following thrombolytic therapy or within 90 minutes after ER arrival, if the client is not a candidate for thrombolytics, should be done. Surgically, once again, the CABG, the coronary artery bypass graft, a cardiomyoplasty, or a heart wrap. And then these clients may be instructed to undergo cardiac rehabilitation, which is a medically supervised program that combines exercise and educational activities to help speed their recovery and reduce or prevent recurring episodes. MONA is the acronym that you need to remember in treatment of someone that comes in with chest pain. So which of the following interventions will the nurse anticipate implementing for a client with a diagnosis of a myocardial infarction? This is D, administering a stool softener to prevent straining with bowel movement. We want to prevent that Valsalva maneuver. So peripheral vascular disease, or PVD, is a condition that affects primarily the blood vessels that supply oxygen to the lower limbs. Examples include PAD, peripheral arterial disease, Raynaud's disease, thrombosis, phlebothrombosis, embolism. Men are going to be affected more than women by PAD in the lower extremities. Complications can include a critical limb ischemia, which is characterized by open sores or infections that do not resolve. And they become progressive. They can also become gangrenous, and they threaten the viability of the limb and may ultimately result in amputation. So PAD, peripheral arterial disease, affects the blood vessels that supply oxygen to the tissues. Restricted blood flow can result in ischemia. The primary cause is atherosclerosis, secondary to obesity, hypertension, hyperlipidemia, diabetes mellitus, smoking, and a family history. These clients may experience what we call intermittent claudication, which is pain and cramping in the lower extremities during activity, and it's relieved with rest. Skin that's cold to touch because it's not getting blood flow to the extremities. So it's cold to touch. We may see numbness in the extremities. We may see skin lesions, minimal hair and nail growth because, again, it's not getting adequate blood flow. And if the leg remains in a dependent position, the skin can become very reddened to the point where it's dark purple and or black. And the pulses are going to be very difficult or even impossible to palpate. We diagnose with an ankle brachial index, which compares systolic pressures to help diagnose or determine the severity of the PAD. It helps guide treatment. CT scan, MRI, and lab tests. Medical and surgical management includes weight loss, daily exercise, smoking cessation, of course, blood sugar control, drug therapy, percutaneous and revascularization. Nurses provide client education on the rationale for lifestyle changes, adherence to the medication regimen, what symptoms to report, foot care, teach the clients to avoid crossing their legs or any activity that may further constrict blood flow, such as tight clothing, and may cause injury. Again, thrombophlebitis, we have gone over this. We may see numbness, tingling, cramping, arterial pulsations absent or below the obstructed area. They may have a mild fever, pain, swelling, tenderness of the affected extremity, that positive Homan sign, bed rest, elevation of the extremity, local heat, analgesic, subcutaneous injections, or continuous IV heparin therapy, along with oral anticoagulants. Venous insufficiency, or PVD, peripheral venous disorder, has impaired venous flow through the deep or superficial veins, often seen in the lower extremities, especially in the medial or ankle aspects of the legs. It may be caused from varicose veins or previous thrombosis, and we see venous congestion developing. In other words, with PVD, we're unable to get the blood back to the heart. It's staying in the legs. So now we're going to start seeing edema. We'll see hemosiderin staining, or that dark brown purplish discoloration of the shin. This is caused by leaking of blood into the tissue. Once they have it, it never goes away. We may also see venous stasis ulcers, fragile skin, and moderate pain. They may have weeping from the skin because there's so much edema. The stasis ulcers are going to be chronic. They're going to be very wet. They're going to have a lot of drainage. They're going to be an irregular shape. Again, a very moist, reddened wound bed. With the PAD ulcers, these are also chronic. They're not getting blood flow, so they're going to be very pale. They're going to be very dry, and they're usually circular in shape. So back to PVD. We diagnose with the Doppler ultrasound. We want to promote venous circulation. And the best way with PVD is compression stockings. We do not do compression with PAD because then we're cutting off what circulation they do have. With PVD, the compression is hopefully going to be pushing some of that blood back up to the heart. We want to do exercises or vascular surgery, teach appropriate wound care, and maybe even hyperbaric oxygen therapy. Make sure that we assess their circulation, assess their compression. We don't want compression 24/7. They need to have a compression-free time. And elevate lower extremities. If you elevate with PAD, you may be draining some of that arterial blood flow back towards the heart, and that's going to create pain from additional ischemia and hypoxia. Varicose veins are valves of the veins becoming incompetent. So in other words, those valves, instead of closing after the blood passes, no longer close appropriately, so it allows blood to backflow. And it results in an overfilling of the veins and a backup of blood, which then creates those varicosities. Causes include prolonged standing, obesity, pressure on the blood vessels from an enlarging fetus, liver, or abdominal tumor. The legs begin to feel heavy and tired, particularly after prolonged standing activity or elevation of the legs. Can relieve some of that discomfort, but the leg veins are going to look distended and tortuous. They can be seen under the skin as dark blue or purple snake-like elevations. We diagnose with a Brody-Trendelenburg test. Treat it with exercise such as walking or swimming, losing weight, wearing elastic support stockings, avoiding prolonged periods of sitting or standing. It may require vein ligation or vein stripping. Nurses should assess the skin, the distal circulation, assess for peripheral edema, the client's level of discomfort, and their ability to do activity or isometric leg exercises, ambulation post-surgery, and anti-embolism stockings. A client diagnosed with varicose veins is reluctant to have surgery to repair them. She asks the nurse what she can do to reduce the pain of varicosities. So the nurse suggests the client C. Avoid sitting or standing for long periods. And finally, aneurysms. This is a stretching or bulging of an arterial wall caused by arteriosclerosis, hypertension, trauma, or a congenital weakness. It may be asymptomatic. We may see massive hemorrhage with pain, discomfort, or symptoms that are related to pressure on nearby structures. We diagnose with x-rays. Aortography can identify the size and location of an aneurysm. We treat it by administering antihypertensive drugs to help keep the blood pressure within a normal range. Excuse me. And sometimes we even want to keep that blood pressure at a lower than normal level because we want to reduce the pressure on that weakened area. Surgically, it may require a bypass or a replacement graft. Nurses keep stress and activity to a minimum. Teach the client to avoid straining during bowel movements, coughing, or holding their breath when coughing or changing position. Basically, again, that helps reduce that Valsalva maneuver, which increases that intrathoracic pressure uh, and can potentially rupture an aneurysm. Monitor vital signs, eyes and nose, and do that skin assessment. We need to know what the color and temperature is.